This video will discuss erythrocyte sedimentation rate, or ESR. The objectives for this video is to be able to define ESR. We will also discuss the different phases in ESR. We will explain some clinical significance connected to ESR, and we will examine the different factors that may affect ESR determination, and we will compare different methods on how we can test for ESR. ESR stands for Erythrocyte Sedimentation Rate. Erythrocyte is another name for red blood cells. Sedimentation means settling down, and the rate refers to how fast or how slow the activity is. Therefore, we can define ESR as the measurement of the degree of settling of erythrocytes that are in plasma collected as an anticoagulated whole blood specimen that is performed in a specified period of time. This is reported as millimeters per hour. Simply put, ESR is the distance in millimeters that the red blood cells can fall in 1 hour at a vertical position. ESR is also easy to perform and inexpensive. Easy to perform in the sense that the anticoagulated whole blood that is collected is just allowed to stand at room temperature without being disturbed for 1 hour. It is also affected by 3 factors: red blood cells, plasma composition, mechanical or technical factors. Given these 3 factors, it means that ESR is also prone to a lot of errors that can falsely increase or decrease sedimentation rate. ESR is used to detect and to monitor inflammation. And there's a lot of conditions that involve inflammation. Examples of these are rheumatoid arthritis, infections, and malignancies. If a patient has these inflammatory conditions, ESR will be elevated. That's why ESR is usually ordered with other tests that can detect and that can monitor the course of inflammatory conditions. ESR is a non-specific measurement. That means it cannot definitively be used as a diagnosis for conditions because it gets elevated in inflammatory conditions. That is why it is not recommended for screening inflammatory patients that are asymptomatic, because it is low in specificity and low in sensitivity. But there is an exemption to this non-specific rule of ESR. There are 2 conditions where ESR may be used as a definitive diagnosis, and these are temporal arteritis and polymyalgia rheumatica. Let's discuss the different factors that may affect ESR determination. The first factor is red blood cell. Now, there are a lot of conditions about a red blood cell that can influence ESR determination. The size and mass of the red blood cell can affect ESR. Its shape can also affect ESR, and the population of the red blood cells in the blood can definitely affect ESR as well. A factor of chief importance in determining the distance that the red blood cells would fall is the size or the mass of the falling red blood cell. The principle is, the larger the particle, the faster it would fall. That's why macrocytes, which are bigger red blood cells, would have an increased sedimentation rate because of its bigger size, while microcytes would have a slower sedimentation rate because of its smaller size. Now, normally, red blood cells are negatively charged, so they repel each other. They more or less are separated. But there are disorders that can alter the negative charge of the red blood cells and may either give a decreased or change it to a positive charge. Now, this would attract the other negatively charged red blood cells, causing either a rouleau formation or an agglutination. Rouleau is when the red blood cells are stacked together like coins. And when this happens, they become larger in mass, therefore increasing its sedimentation. Agglutination can also increase sedimentation. This is when the red blood cells are all clumped together, therefore also giving an increased cell mass. Other red blood cell conditions to consider in ESR determination would be red blood cell shape. Anisocytosis and poikilocytosis can both decrease the sedimentation rate. These conditions can reduce the ability of red blood cells to form large aggregates, therefore giving a decreased sedimentation. Anisocytosis is when majority of the red blood cells have differing sizes. Some may be big, some small, and some normal, while poikilocytosis is the change in the shape of the majority of the red blood cells. Examples of poikilocytes are sickle cells and spherocytes. Now, both these conditions have an alteration in shape, therefore unable to aggregate and form a rouleau. Another RBC condition to consider is the RBC population. Anemia is the decreased red blood cell concentration in the blood, and anemia with its decreased red blood cell would cause an increased sedimentation because of the lesser RBC population, and that when there is more plasma, this would favor rouleau formation, giving an increased sedimentation rate. On the other hand, polycythemia is the opposite of anemia. This is an increase in red blood cell concentration, therefore giving a decreased or generally a normal ESR rate. Another factor to consider is plasma composition, and this is an important factor when we are trying to determine erythrocyte sedimentation rate. One of the components of plasma that affects ESR are the acute phase reactants. These are plasma proteins that can control the rouleau and aggregation of red blood cells. When there are increased protein concentration, for example, fibrinogen or alpha-1 globulin, beta-2 globulin, or gamma globulins, an increase of any of these acute phase reactants would cause rouleau and aggregation of red blood cells, therefore increasing sedimentation. But there are exemptions to the proteins that increase ESR. Examples are albumin and lecithin. Both of these proteins or acute phase reactants decrease erythrocyte sedimentation rate. So how do these proteins affect rouleau and aggregation? When the proteins are positively charged, they can counteract the negative charge of the red blood cells to each other, and that can cause the settling of the red blood cells to be faster and more efficient. Other factors in plasma is plasma viscosity. The more viscous plasma is, the slower the ESR would be, and the less viscous plasma is, the faster ESR would be. Plasma cholesterol can also affect ESR. An increase in cholesterol levels would also accelerate erythrocyte sedimentation rate or increase ESR. The third factor to consider in ESR determination are the different mechanical or technical factors, and there's a lot of these factors that can affect ESR, making it very prone to erroneous results. The first one is the length of the tube used for ESR. The longer the tube, the faster ESR would be. This is because when the tube is longer, there would be more space at the bottom wherein the cells can start settling down. Another factor is the position of the ESR tube. The ESR tube, when left for 1 hour for settling, should be exactly perpendicular. Any inclination, even if it's 3 degrees tilt, every 3 degrees tilt, would cause a 30% error, and that means there would be faster ESR. This is because the red blood cells would have a shorter distance through which to settle down because of the tilting of the tube. The next one is any vibrations or drafts or sunlight that the tube is exposed to can increase ESR. Even just minute movements or vibrations would cause a false ESR result. The next one is temperature. Temperature is directly proportional to sedimentation. So the higher the temperature, the faster ESR would be. The ideal temperature is at 22 to 27 degrees, which is room temperature. So when the room is hotter than room temperature, the faster your ESR would be. A next one is the tube diameter. A narrower bore would give a lower sedimentation, and a wider bore would give a faster sedimentation. Other mechanical and technical factors are as follows. First is bubbles. The presence of bubbles would give a faster ESR because the bubbles present in the tube used for ESR, which come from maybe extraction or the pipetting, can take the place of the red blood cells that should be in that tube, therefore making a lesser concentration of red blood cells. And as said earlier, a decreased concentration of red blood cell would cause a faster ESR. Next one is anticoagulant. The function of anticoagulant is to inhibit rouleau formation. Therefore, the presence of excess anticoagulant used for collection would slow the ESR. The next one is the age of the specimen. The specimen should be processed as soon as possible. If a specimen that was extracted for more than 2 hours is processed, this would give a slower ESR because as the specimen ages, the red blood cells become spherical in shape. And as explained earlier, a poikilocyte or a change in the red blood cell shape would cause a slower ESR. And lastly, we have the time of reading the results. The results should be read at exactly 1 hour. If the result is read before 1 hour, it would cause a lower reading because the final settling of the RBCs has not yet occurred. Here is the summary of all the factors that can influence ESR. For those that are directly proportional, an increase in the size, the presence of the proteins, tilting of the tube, or an increase in temperature would all increase the values of ESR. And those that are indirectly proportional, the increase in red blood cell count, the presence of a red blood cell shape deformity, the increase in plasma viscosity, the presence of albumins, the presence of bubbles, the excess anticoagulant, and the older the specimen is, the lower the ESR would be. So what is now the significance of this test? Why is ESR important? First is that it represents a non-specific response to tissue damage and inflammation. Inflammation causes the increase of the acute phase reactants. These plasma proteins can directly affect ESR. For tissue damage, like degenerative diseases or tumors, and even most acute and chronic infections, can cause changes in the plasma proteins as well. Second, it denotes the presence of diseases like tuberculosis and carcinoma, but it cannot detect its severity or its level. Next, it reflects the changes in the plasma proteins. That means that it can denote the abnormal concentration of plasma proteins like fibrinogen and serum globulin. And fourth, it is used to follow the progression of certain diseases. Since these diseases can affect the plasma proteins, this can be used to see the progression or to monitor the progression of diseases like tuberculosis and rheumatoid arthritis. There are 3 stages for ESR. The first one is the lag phase, followed by the decantation phase, and the last phase is known as the final settling phase. The first stage is the lag phase. This is the first 10 minutes of the procedure. So after transferring the blood into the tube, the first 10 minutes would be considered as the lag phase. In this lag phase, the red blood cells will start to form rouleau. So this is the initial rouleau formation of the red blood cells. Now, since rouleau is only starting, there is only little sedimentation. Only a little bit of the portion of the blood is starting to settle. The next stage is the decantation phase. This is the next 40 minutes. So the first 10 minutes is the lag phase, followed by a 40-minute decantation phase. Now, since there's a lot more time for this phase, that means there would be more time for the red blood cells to form a rouleau, and therefore making it more rapid in settling. This is where there would be a constant red blood cell sedimentation. This is when most of the red blood cells have started to fall down at the bottom of the tube. The third stage is the final settling phase, and this is the last 10 minutes of the procedure. The first two stages are the 50 minutes, and the final settling phase completes the 1 hour, which is 10 minutes. This is when the red blood cells would have a slow sedimentation, since most of the red blood cells have already fallen down at the bottom of the tube on the first two steps. On the third stage, there would only be little red blood cell sedimentation. So this is the final settling or the final packing of the red blood cells. There are different methods that may be used in testing for ESR, and we will briefly discuss some of them. There are different methods that may be used for ESR determination, and they can be categorized into two. We have the macro method and the micro method. Macro methods may include any of the following: the Wintrobe and Landsberg method, Westergren method, Graphic-Cutler, Linsen-Meyer, Rourke-Ernsten, and Bray method. The micro method are the following: Micro-Ladau method, Smith-Micro, and Christa or Hellige-Vollmer method. The first method to be discussed is the Westergren method. The Westergren method uses a Westergren tube, which is a long tube measuring 30 centimeters long. This tube is open in both ends, with bore sizes of 2.5 millimeters in diameter. The calibration of this tube is up to 200 millimeters, and it can hold up to 1 ml of blood. The Westergren method is read twice. It is read after 1 hour, and another reading is done after 2 hours. This is the most sensitive method for serial study because of the 2 readings done. Anticoagulant to be used for this method is 3.8% sodium citrate. The second method is the modification of the Westergren method with a few adjustments. Westergren tube is still used, and one modification is the anticoagulant. EDTA is used for the modified Westergren method, and it is only read after 1 hour. Diluents to be used are 0.85% sodium chloride or 3.8% sodium citrate. The third method is the Wintrobe method. It uses the Wintrobe tube, the same Wintrobe tube that may be used for hematocrit determination. But this time, we should use the side on the left, which reads 0 to 100 from top to bottom. Either EDTA or double oxalate may be used as anticoagulant. The next method is a micro-ESR method, referred to as the MESR. It uses a heparinized microhematocrit capillary tube with 0.2 ml of blood, and this is usually used for pediatric patients. Another method for ESR determination is the ZETA sedimentation ratio. This uses a ZETafuge, which is a centrifugal device. The problem is this is no longer produced. The ZETafuge spins the capillary tubes in a vertical position in 4 cycles of 45 seconds each. That means that a sedimentation ratio may be given in just 3 minutes. The capillary tubes are read like a hematocrit reading. That is why this is referred to as a ZETacrit. To get the ZETA sedimentation ratio, we divide hematocrit over the ZETacrit. Unlike the other sedimentation methods, the ZETA sedimentation ratio is not affected by anemia and is easier to interpret. One of the automated methods used for ESR determination is the Vestmatic. This is an instrument that provides automated mixing and infrared point determination. A sedimentation rate may be given in 20 minutes. This is considered as a safer, quicker, and a more standardized way of measuring ESR. Other automated methods that may be used are the SEDI system by BD and the test one by Sire Analytical Systems. For the reference range using the Westergren method, as this is the reference method recommended by the ICSH. For individuals ages 0 to 15 years old, male would have a 0 to 15 normal value, while female would be 0 to 20 millimeters per hour. Older individuals of more than 50 years old, males would have 0 to 20 and females would be 0 to 30 millimeters per hour. As you can see, females have a slightly higher value compared to the male. This is due to the concentration of androgenic steroids that is present in male. So testosterone and other androgenic steroids in males decreases ESR value. To summarize, these are the following conditions that can cause an increase in ESR values. Tumors like plasma cell myeloma can increase ESR. Anemia and old age were explained earlier on how they can cause an increase in ESR. Pregnancy after the 3rd month usually increases ESR. Infections, acute and chronic, may also increase ESR. Inflammatory processes like rheumatoid arthritis can cause increased ESR. Tissue damages like myocardial infarction and nephrosis can increase ESR. Also, menstruation and macroglobulinemia can increase ESR. The following conditions would cause a false decrease or a normal result. Polycythemia, which is an increased concentration of red blood cell, can cause a decreased ESR. Congestive heart failure, hypofibrinogenemia. Fibrinogen is an acute phase reactant, and a decreased amount of fibrinogen in the blood would also cause a decreased ESR. RBC abnormalities like sickle cell anemia, hereditary spherocytosis, and hemoglobin CC disease can all cause a decreased value. Now the question is, why would these conditions cause a normal value? If you remember, the normal values start with 0. So that means these conditions can cause a false decrease, and therefore they might give or be reported as a normal value. That would be all for ESR determination. Thank you very much for listening.